este momento. Y voy a dar unas breves palabras de introducción a Carla y luego el seminario. El seminario tiene por título Ejercicios complejos para la enfermedad de Parkinson y particularmente personas con freezing of gait, congelamiento de la marcha. Y Carla hoy día gentilmente va a dar la charla. Nosotros pertenecemos a una asociación que busca agrupar a los profesionales que trabajan en neurorehabilitación en la región. Nosotros tenemos la misión de avanzar en el desarrollo y mejorar la calidad de la neurorehabilitación y facilitar el intercambio de conocimientos e investigaciones científicas entre todos los profesionales en neurorehabilitación y estimular la colaboración entre nosotros. Básicamente te puedes unir a la asociación y ser parte de la Federación Mundial al mismo tiempo por una suma no mayor. Y todo esto está en la página web que yo la voy a compartir por el chat. Y en el caso de los estudiantes, esta es una inscripción gratuita y permite participar de esta instancia u otros eventos de la asociación. Carla, fisióloga de ejercicio, kinesióloga en Brasil, de la Universidad de Sao Paulo, tiene un doctorado en ciencias de la Escuela de Educación Física y Deporte de la Universidad de Sao Paulo. Tiene un postdoctorado también en la misma universidad, en Sao Paulo, y actualmente es investigadora postdoctoral en la Oregon Health and Science University en Estados Unidos, en el estado de Oregon, en el laboratorio de desórdenes del balance, junto a Martina Mancini, Faye Horak y Lori King. Bueno, yo también participo con Carla en el mismo laboratorio. Así que sin más palabras, le doy las gracias a Carla. Carla, you can continue now in English. Oh, sorry, I will say the last thing in Spanish. Nosotros intentamos traducir las charlas, pero la nueva versión de Zoom, por lo menos la de mi universidad, quitó la opción. Así que lamentablemente esta vez no podremos interpretar. Y la opción que hay es poner los subtítulos, así que eso está habilitado y pueden ir leyendo en inglés. Y no estoy seguro si va a funcionar en español, pero por lo menos pueden ir leyendo la transcripción de Carla en el Zoom. Así que yo ahora voy a terminar de compartir y voy a dejar la presentación de Carla. Y estamos listos. We are ready, Carla, for your presentation.
Thanks, Pablo, for the introduction. And thanks everyone for being here virtually. So like Pablo said, I'm from now Balanced Disorders Lab in the Neurology program. And I'm going to talk to you about our project that we have doing. And basically this project we conduct in the University of São Paulo in Brazil during my first part of postdoc. And I hope you can enjoy this presentation about complex exercise for people with Parkinson's disease and freezing of gait. So I have basically four points to discuss with you about what is Parkinson's disease and freezing of gait, the types of fog manifestation, because you have different subtypes of freezing of gait, why we need to start thinking more about exercise to manage freezing of gait, because we have some therapies about medication and deep brain stimulation that don't have a great effect on freezing of gait yet. And the 4 point basically is I'm going to talk about my project that we have used in some type of complex exercise that I'm going to explain a little bit later. And in the end, I'm going to do the conclusion about this talk. So let's start with the first topic. What is Parkinson's disease and freezing of gait? So basically, Parkinson's disease is a progressive, chronic, and neurodegenerative disease. So the main characteristic, the morphological characteristic that we can find in the brain of patients with Parkinson's disease is the loss of pigmentation. The dark pigmentation is melanin, specifically in the substantia nigra. And this loss of this dark pigmentation is associated with loss of dopaminergic neurons in this region. And another characteristic about this pathology is patients have some accumulation of alpha-synuclein in the Lewis body that basically is abnormal cytoplasmatic aggregation of these markers in the brain that is associated with loss of dopaminergic neurons. So this loss of dopaminergic neurons are also associated with the cardinal characteristics for Parkinson's disease, including bradykinesia, rigidity, and the tremor, and in terms of gait as well. So I like this review because they show the PD progression in the prodromal phase and in the later phase of the Parkinson's disease. So you can see here that 20 years before the cardinal symptoms start to appear, people have some early symptoms associated with constipation, sleep disorders, depression, and they are some predictors for Parkinson's disease development. And when people get the diagnosis based on the cardinal symptoms, freezing of gait specifically is not present in the early stage of Parkinson's disease. It's more present in the later stage, but there are one systematic review published in 2021 that showed that prevalence of Parkinson's disease and freezing of gait is almost 40% in the previous 5 years of the diagnosis. And 60% of the people develop freezing of gait in advanced stage, like after 10 years of the diagnosis. So it is just to keep in mind that we are going to have some patients with freezing of gait that they will have in early stage, but the most of them will be present in the late stage of the disease. And you need to take account other Parkinsonism related with freezing of gait, like PSP, for example, or MSA. And this type of Parkinsonism, people have more freezing of gait and falls in the early stage of PD. So it is not necessarily freezing of gait related with the idiopathic Parkinson's disease. Okay, so freezing of gait definition now is available in this paper that was published this year. So before, we had a definition from Professor Nutt, Dr. Nutt, from Oregon Health Science University here, that Pablo and I work together. And he has a previous definition about freezing, more specifically for shuffling, small step, and that people need to have don't have progression to moving forward. But this new definition, they have one more generic definition about all the type of irregular steps or paroxysmal episodes are associated with freezing of gait. So basically the definition is paroxysmal episodes, even people that is tentative to trying to step forward. So I think it's better if you take account this new definition because you can include together all the types of freezing of gait. For example, the second topic I'm going to talk is about the types of fog manifestation. This type of fog manifestation, we have different ones, and all of them are included in this definition. So, for example, let me take my laser point. Okay, so we can talk about this first video. So I put here the 4 manifestation of freezing of gait or 4 subtype of freezing of gait. So the first one is the alternating trebling of the legs during the turning. So we know that the turning task is the main trigger for freezing of gait. And people say, oh, just turning 45 degrees, 180, 90 degrees. This one is specifically people need to do 360 degrees alternating between right and left. So they need to do a completely turning. And it was found that turning is the main trigger because people with Parkinson's disease and freezing of gait, they have in block turning. So Pablo is working on one paper with data in the OHSU. They are trying to see this difference in sequential turning in people with Parkinson's disease and without Parkinson's disease. And previous paper have shown when freezers need to turn, they have this in block. They don't have the top-down control of the turning, like head, trunk, hips, and legs. So they just turn in block. So, and we think this is the main trigger for freezing because this behavior of turning as well. So here you can see this participant, he was asked to turn 360 degrees, and you can see this trembling of the legs. And this is the main characteristic of the freezing of gait. So this is the first one. And we have another one that is a trigger for freezing as well, when you ask people to do a doorway and turning the end. Let's show here. So people just walking straight ahead, no freezing, but when they need to turn, there is some trembling on the leg as well. So this is the main characteristic for freezing of gait. So the second characteristic of freezing of gait is akinetic freezing of gait, when people have no movement of the legs at all. So again, you can see here, let me show you this turning. This turning that we ask people to do is 360 degrees as well, but with narrow space. So you can see here, people start to turning, and he was just asked to turning. He's trying, but he has no movement at all at the legs. So we say akinetic freezing of gait, no movement. So this is another one that we ask this guy to walking straight ahead and in the end turn, to do 180 turn. And this person is trying to take the first step, but he has no movement at all. So we say this classification akinetic. So let's go to the third one. The third manifestation is step initiation failure or start hesitation. So this guy was asked to take the first step. And you can see a lot of hesitation before he moved forward. So, and we have some hypotheses for that. We have hypotheses that they present a lot of weight shifting between legs and a lot of postural sway, and it don't help this participant to release the stepping program. Okay, so let's go to the last one. So this last one, we say fascination together with shuffling. So this participant was asked just to walking straight ahead, and he present a lot of shuffling and a small step with minimal forward progression, but they have like acceleration of the body. So looks like he's being pushed ahead. So we say fascination for this one, but since the definition of the fog is more about the paroxysmal episodes and the inability to step effectively, we just have using small shuffling with inability to move forward. But if you say fascination, it works very well. So we have these manifestations of freezing of gait. We don't know exactly if different types of rehabilitation, including levodopa, deeper brain stimulation, and exercise, can have great effects on these specific types of subtypes of freezing of gait. But the main use as outcome, primary outcome, the most of the studies is trembling when you ask people to do 360 degrees. Okay, And I'm going to talk about that when I say the effects of complex exercise in freezing, in people with freezing of gait. So, like I said, turn is the main trigger for freezing of gait. So this one is just an example for you. See, you ask people to walking straight forward and to do a time open goal test that they need to do a 180 degrees. So you can see just more hesitation than trembling per se. But now when you ask people to do 360 degrees, it's the main trigger for freezing of gait. So you can see a lot of trembling, hesitation. So these have been used like primary outcome in studies. So this study was published by Dr. Manchin, that we work as a director of the Balanced Disorders Lab, and she developed a freezing of gait ratio that take account the acceleration and trembling of the legs during the 360 degrees turn. And she found great association with clinical freezing of gait severity and the subjective scale to assess freezing of gait. So that's why I told you we are going to talk about this freezing of gait ratio for to see effects of exercise. Okay, so why you need to start thinking more about exercise to manage freezing of gait? So this was a review published last year by the group of Kinonics from Holland. So they have some recommendations to treat freezing of gait. So the review is really large. This review is great with a lot of information. So I try to take just one table and summarize the main recommendations. So we know that levodopa is the main gold standard treatment for reducing cardinal symptoms of Parkinson's disease like rigidity, bradykinesia, tremor. But for freezing of gait, there is a big interrogation if levodopa can treat freezing of gait or not. So we have some studies that show that freezing of gait is more present in people who take levodopa. And Professor Bastian Bloom and the Kinonics, they have one paper published 2 years ago about like some recommendation. If people take medication, they need to be followed because in some patients, long term of levodopa intake can cause freezing of gait. So that's why levodopa, there is this controversial results in terms of it decreases the freezing of gait or it causes freezing of gait. So they have this recommendation that you need to reduce dosage in patients that feel freezing of gait when they are on medication. And levodopa is not indicated more if people are dopa unresponsive freezing of gait. So if you ask me, levodopa decrease freezing, so we have these controversial results. We don't know yet. So another therapy that they recommend is deep brain stimulation. So deeper brain stimulation we have in subthalamic nucleus and the global pallidus. These two areas the most used in the literature to treat motor symptoms of Parkinson's disease, including tremor, rigidity, and bradykinesia. So we don't know the real effect of DBS in balance outcomes and the freezing of gait. So we have here at OHSU big cohort of people, more than 200 people, and we have this data analyzed, and we are in preparation of the manuscript. And this data that I am analyzed, GPI, deep brain stimulation, globus pallidus internal deep brain stimulation, don't have a great effect on balance using mini-BAS test, and don't have a great effect on falls and freezing of gait as well. Some people got worse, other people don't change, and 20% of the people improved, but it's low percentage. So, but DBS is still indicated to control motor fluctuations. And when on-state fog is persistent, because you can decrease levodopa dosage when you have DBS. But again, we have these controversial results about DBS effects on freezing of gait. And in the final recommendation is about exercise. So we know that exercise is really important for different symptoms of Parkinson's disease and include freezing of gait as well. Don't have a lot of great data about exercise prevent freezing of gait. It can reduce, but we don't know if it can prevent freezing of gait. But we have some data and a lot of studies about cueing, vibratory vibration, auditory and visual cueing. And this type of cueing can decrease freezing of gait, but it has some immediate effect, and it is not persistent and retained after when you remove cueing. So basically, it's more the immediate effects of cueing. So that's why I start to investigate the different types of exercise, and my focus is more in complex exercise, and I'm going to explain why. But before I start to talk about complex exercise for this population, I have this systematic review to present that was published by Dr. Moran Gillette. And they just take account all the type of exercise for people with freezing of gait. And they separated this type of exercise in 3 categories. So they said the first one is more fog specific. What means that? It is more cueing, because a cueing is more focused on freezing of gait. For example, visual cueing, there is a great paper in the Lancet. This was the first one that showed the case study when people have some lines on the floor, and when people with freezing of gait need to pass, they step over these lines on the floor, freezing is just automatically disappear and reduced. So, and there are other studies that using auditory cueing, that people use this rhythm of the cueing to help them to work better and keep the gait pattern, and can help them to overcome freezing of gait. And the vibration cueing is another type of cueing. We have worked with vibration at the Balanced Disorders Lab. Dr. Manchin, the director of the lab, she developed one device, the vibrotactile cueing, that is it's delivery vibration during the stance phase of the gait. And this vibration, this vibrotactile cueing, relieve freezing of gait episodes, so reduce automatically. But again, we don't have ideas about if this reduction in the freezing of gait can be sustained after cueing removal. So the long term of these effects, we don't know exactly. So in this systematic review, they said fog specific using this type of cueing. And the second definition is fog relevant. What means that? Basically, are exercise that can have some triggers on components in freezing of gait. For example, we know that freezing of gait, people have more when they are doing dual task, for example, because the overload of cognition can cause more freezing of gait. So this is one type. And another one is when you ask people to do some transitions, like step initiation, turning, they have much more freezing. So this is another fog relevant using APA. Another one is when you have some unstable or instability exercise and conditions that people feel more trembling on the legs and they feel more freezing of gait. Another one is we know that freezing of gait is triggered when you have some anxiety situations because anxiety cause freezing of gait. So if you have this situation that people need to cross doorway, walking in the dark, so they have more freezing episodes. So if the exercise program involves these aspects like dual task, APA, walking during stress conditions or anxiety, it was defined as fog relevant. And the last one they separated in this model was only exercise, more generic exercise. For example, swim, like aquatic exercise, just walking outside, strength training alone without any type of cue or challenging or complexity, and balance exercise that are not trigger for freezing. So it was defined as generic exercise. So in this systematic review, basically they separate in these three types of exercise, and they include this type of queuing inside the fog specific. And I think it's good if you can have this website here. I can send and put in the chat, or you can just take a screenshot, because in this website they have some types of queuing that they have work with patients with Parkinson's disease. And this is really interesting. So there are different type and experience from patients. Patients just have freezing of gait. They develop some strategy or compensatory strategies, and they upload on this website and say some like summary about his life and condition. Okay, so this systematic review uses these three separated models, and when you look at this forex plot to see which model could be more effects on subjective freezing of gait severity, we can find a higher effect size for freezing of gait relevant types of exercise. So queuing has effect, but is small effect size, and the generic exercise have no significant effects on subjective freezing of gait. So they recommend that people use queuing, but also relevant exercise that are trigger for freezing of gait, such as dual tasking, APA, turning, sensory stimulation or sensory motor intervention, and more trigger for freezing of gait like anxiety. Okay, so let's go for the next topic. Since we know that freezing of gait relevant exercise are really have like great effect size, this type of exercise, complex exercise, are really important for freezing of gait, because in this theoretical model of gait control in Parkinson's disease, they have large compensation. So the idea for freezing of gait to be overcome is because people have a higher compensation in different cortical areas, including frontal lobe, visual lobe, and auditory lobe as well, temporal lobe as well, and the parietal. So all these lobes are really compensated when people start walking and they have freezing of gait, because they need to overcome freezing of gait. But during the disease progression, this area is starting to get some degeneration, and the freezing start to get worse because they don't have a lot of compensation. So we start to think, if we work in these areas with this type of exercise simultaneously and together, it could be beneficial for decreasing or reducing freezing of gait severity. So we start thinking about how you can implement sensory-motor integration to activate parietal lobe, visual lobe, for example. How we can integrate some complexity to trigger cognition, to work with frontal lobe, for example. And how you can train the fear of falling to manipulate the limbic system. So we start thinking some type of exercise that could integrate all these components together simultaneously. And we develop the resistance training with instability. So we have published a lot of papers about this condition, this type of exercise in people with and without freezing of gait, in mild and severe stage of Parkinson's disease. And we have found that this type of exercise have great results. Have shown great results on cognition, mobility, gait, automaticity, and in brain areas as well. So, what is this resistance training with stability? So here is basically you need to ask people to do some conditions that are triggered for freezing of gait. For example, APA, that people need to take step forward to work APA on unstable conditions, to work with sensory motor integration, and with load as well to improve this sensory motor integration and the neuromuscular pathways. And another thing is about this dynamic balance control. Let me take out this one here. This dynamic balance control during APA. And this unstable device, they cause fear of falling because people need to hold the balance all the time. So we start to think about these three aspects and together with dual task to improve cognition. And you have worked simultaneously in these components in this program of exercise for improved freezing of gait. And another thing that we realize is when people work with this instability, this in block that they have to turn, for example, they have loss of mobility in the trunk and the hips. So when you put this unstable device, people have this desynchronization between hips, trunk, so they need to have more mobility on these core muscles that help them to have less in-block condition. And you can do some adaptations for people who have a lot of fear of falling. So we have this half squat exercise that people have this unstable on the feet and the physio ball on the lumbar, on the trunk. And for people who have a lot of fear of falling, you can do some adaptations here. And another one is doing this exercise while you have some motor dual task, when people need to do some disassociation between arms while they are doing some half squat. So this exercise is really challenging and you need to be supervised do one by one. And this progression is like the last session of the intervention. So in the beginning session of the intervention, the first session, so people performed 36 sessions. The first session, people are just doing some exercise without unstable device, just to understand the movement. And we have some progression to implement the instability, the degree of instability. So this is the last session of the program. That's why people are performing really good. Okay, so here, let's put my laser pointer again. So, and here we have this protocol of this exercise, and people performed 7 types of exercise, always with the instability placed on the most important limb that they need to do a more application of the strength and hold balance. So basically, we progressed on unstable device, load, weight, and challenging. So during this protocol, we take account these three components for progression and how we did with unstable device. So unstable device was changed to less unstable to more unstable device. And basically, when you see the participant decreasing the body sway and the force production increase a lot, we starting selecting more unstable device. And the progression of the weight was systematically increased between 5% to 10%. And we used the linear periodization that have research in the sports science have used for athletes. So this linear periodization, we start with high volume and the low intensity in terms of load, weight. And we finish with higher intensity and low volume. So this was the linear periodization that we used. So, and always progressing together. And our focus was more instability and stable than weight. So in some case, that we progress weight and instability if people presented a lot of postural sway and unbalance, we decrease the weight to keep the focus on instability, on progression on the stable device. And during all the protocol, people was asked to keep her perception in terms of exertion similar or above 7. So they need to be more like close to 10 to have more challenging in terms of progression and complexity. And we ask for them both rating. So in terms of complexity and in terms of load. So in terms of complexity, because they have the instability with dual task, and in terms of load, if the load was really, really heavy. So this is our protocol. This is the table that we have a protocol with in between weeks that people need to progress. And basically they did 36 sessions because it was 12 weeks, 3 times per week. And the session was like longer, no 1 hour, because we need to set up the unstable device, explain the exercise. People was like severe, most of them. We had people in stage 3 and 4. So it's taking like a while to set up the scenario for the exercise. So for this study, we had 17 people in the resistance training with instability group and 15 people in the control group. So basically the control group, they perform generic exercise with no challenge, with no progression in terms of instability, just progression in terms of load. So, and it basically was resistance training, strength training alone, without progression in terms of instability, but they perform some balance tasks as well. We say for this control group, it was more traditional motor rehabilitation that people take account. Some balance, some gait, and some resistance training exercise, but without challenging, without instability. So you can see here the characteristics of our population. Most of them is stage 3 to 4. We have much more moderate stage of Parkinson's disease than severe stage, like stage 4. So, and the most of them are like older and have like no severe cognitive impairment. So we use like mini mental scale and not MoCA scale. MoCA was used as outcome, not like a screen. And they have these results as well. And they were in unstable medication before participating in this study. And they didn't change the medication as well. So this was the first study that we published with this type of exercise for people with freezing of gait. So like I said, the freezing of gait ratio, the trembling when they are turning, are the best for now, the best outcome that we have to show freezing of gait severity more objectively. New freezing of gait scale is not recommended for outcome. It is more recommended for screening. So, but even so, this study was published before the screening. The paper about the screening was being published. So we didn't know about this before. So that's why we assessed the new freezing of gait questionnaire. And if you see here, resistance training with instability decrease in 4 points, this scale. But again, it is not really relevant data because this scale have been more used for screening. But when you look at foggy ratio during the turning 360 degrees, that is the main trigger, resistance training with instability, they have the trend to decrease, but the post-assessment have much more effect than the post-assessment in the control group. But it was because the control group got worse in terms of freezing of gait severity. And UPDRS scores that assess the cardinal symptoms of Parkinson's disease, they got much better in resistance training stability, but they got worse with the control group. So we are not expecting for that to got worse, but in terms of freezing of gait and PIGD, postural instability, and gait disturbance, this subscore got worse in this population. So when you look at the brain activity, we saw that when people perform this exercise with resistance training with complexity, they have higher brain activity in this area related with visual and temporal areas that are related with APA and visual sensory control, but they increase the brain activity in locomotor areas related with freezing of gait pathology, like cerebellar and mesencephalic locomotor regions. So these areas are related with locomotion, automaticity, and APA, anticipatory postural adjustments as well. So in this study, we show that freezing of gait during the turning may decrease, and it is associated with this brain change. In this another study, we found that complex exercise improved cognition in these patients, and the cognition was assessed using the scales for example, MoCA, frontal assessment battery, this digit span, trial-make test using this subtraction B part minus up A part that show cognitive flexibility, and the stroke test that show cognitive inhibition. And we found that only resistance training stability decrease, but it's not more effective than the traditional motor rehabilitation, just to have effects from pre to post. And improvements in freezing of gait ratio was associated with this frontal assessment. And the part of this study was developed by my student in Brazil, and she published this study about automaticity. So we know that people with freezing of gait, they have loss of gait automaticity, and you can assess gait automaticity using the dual task cast. dual task walking minus single task walking divided by single task. And what you found, you did some analysis using delta change between groups. And you can see here more change for resistance training with stability than traditional motor rehabilitation. Traditional motor rehabilitation have a good results in single walking, in single task, and for gait speed and stride length, but resistance training was better. And we think that this control group improved walking single task because they have this gait training just straight forward without turning. And improvements in dual task cust was associated with increasing in cerebellar locomotor region that is associated with automaticity as well. So we have this, the next two studies that I'm going to show are in preparation from my PhD students in Brazil. They are assessing the effects of this intervention on brain connectivity, because like I told before, people with freezing of gait, they have higher compensation in different frontal lobes, in different lobes in the brain, like frontal, parietal, visual, and temporal. So the idea here was to see if this compensation could be decreased when you apply resistance training with instability, because the idea is to have more neural efficiency when you apply more challenging exercise. And she found this line, blue line, means decreased connectivity. She found decreased connectivity between cortical areas related with visual and cognitive parietal sensory areas with globe pallidus. So she found this decreased connectivity in this area and reduced connectivity in the attentional control areas as well. So, and this change in connectivity was associated with change in fog ratio after the resistance training with stability. So looks like freezing of gait got better because they have decreased in compensation in these cortical subcortical areas. And another study that is being in preparation is by Felipe, another PhD student in Brazil. And I forgot to say Elisa. And Felipe, my PhD student in Brazil as well. He's worked together with Elisa, but he analyzed other MRI approach. This is more DTI, tractography, to see if exercise, resistance training stability can change the white matter integrity, specifically in this region, the corticospinal tract, because we know that people with freezing of gait, they have reduced excitability in corticospinal pathways. So the idea was to see if the resistance training can increase this integrity of this tract. And he found that both interventions increase this integrity of this area. But resistance training stability is more effective than traditional motor rehabilitation. So this result was really nice because people with freezing of gait, they have a huge difference between hemisphere, left and right side. The right side is more affected. And the literature show that the right hemisphere is more affected in freezing of gait using different MRI approaches, like structural, functional, resting state. And we have like great hypotheses about why right hemisphere get worse in people with freezing of gait specifically. Okay, so I stopped talk about resistance training stability. And now I'm going to talk about turning. Like I said, turn is the best trigger for freezing of gait. And here was a video that Dr. Mancini and Professor Horek just shared with us. This one just to show that people turning a lot at home. So they have, like in the kitchen, for example, 45 degrees turn, 180 degrees turn, 90 degrees turn, 360 degrees turn, and the turning is critical for daily life. And it's hard to control, mainly for freezes that I said they have this in block turn as well. And the turning is the best one to discriminate fallers from non-fallers. And Dr. Manchin has a grant that she's trying to investigate if turning can discriminate early PD, untreated PD, that they not take medication from control people. So, and why do you care about turning? Because turning is most affected mobility in PD. So it was the study published by Naoya. He's from Japan. He was doing a postdoc supervised in the lab. And he just assessed, he did some analysis to see which domain is more affected in Parkinson's disease, assessing almost 150 people. And he found that turning velocity is present a large effect size in terms of impairment compared to health controls. That's why we are working a big project, multi-site study in Brazil, here in OHSU, and in Arizona, Phoenix, in US as well, to see if one intervention developed to trigger turning and the aspect of turning could decrease freezing of gait. So this is a big multi-site study, like I said. We are still in ongoing process of this study, so the data collection is ongoing as well. And the fog ratio, like during turning, 360 degrees that I shared, is one of the outcome for this intervention. And basically the intervention is using constraint focus in therapy for freezing of gait, include all the aspects that can improve turning. Like I said, the turning is in block. They don't have top-down control of the turning using disassociation between head, trunk, shoulder, hips, and feet. So you need to improve this mobility in these areas. So you have axial rotation, you have weight shifting to work with APA, you have turning per se, 360 degrees, 19, etc. And some cueings, but cueing is supposed to decrease and remove and just to work with some aspects of exercise that are triggered for freezing. But this is ongoing. We don't have data yet. We are still collecting like 5 people each site. Let's see if in the next 2 years we have this data published. Okay, so I'm gonna stop my talk and doing some conclusion. So like I said, resistance strength stability is more effective than traditional motor rehabilitation that don't use complex exercise. And we have found improvement in motor symptoms and freezing of gait severity during the turning. But again, the resistance training got improvement in turning because the control group got worse. And the gait automaticity improved as well. And it was associated with this change in brain regions, more associated with locomotor parameters. And for you take home message, resistance training stability, but not traditional motor rehabilitation, can be really interesting for freezing of gait rehabilitation, mainly for patients that present freezing of gait in all medication state, like in the study that I showed that we conduct was patients assessed in all medication. And they present freezing of gait in all medication. So this is the new definition for freezing of gait is paroxysmal episodes, despite attentive to walking or take step. And we have different types of manifestation of freezing of gait. 360 degrees, the best trigger. And the fog management is still a challenging. Use DBS, levodopa, and exercise as well, because we don't know if the resistance strength stability got great retention effect. We didn't have retention assessment as well. And turning fog intervention that I just showed, stay tuned. because it could be a great intervention to reduce freezing of gait. And thank you so much for being here. And I am open for questions.
Thank you, Carla. The question will be read by Dr. Jorge Hernandez from Mexico. And in name of the association, we are really grateful, and yeah, we are. It was a great talk, and we have some questions in the chat. And then, Dr. Hernandez, if you can continue, and probably we will talk in the both languages from now.
Thank you, Professor Carla, for this wonderful presentation. So I have a couple of questions for you. The first one was written by me, so I'm going to start with that. I ask you, do you recommend to add to the therapy the use of a metronome during the exercises?
Oh, this is a good question. So we didn't use no type of cueing, like metronome, the auditory cueing, but I think it should be great to help people to engage in some types of exercise, mainly APA. I think if you implement auditory cueing since the beginning, you can help people to improve this rhythm to automaticity. But unfortunately, we didn't implement queuing. So in this last study that I show about the turning, we have a queuing device. So let me show you here. Yeah, you have the metronome here to help people to get better rhythm during the gait as well. But the idea is to start with queuing to help them to synchronize with exercise, but decrease the cue until removal, total removal of the queuing. Because they start to get dependence on queuing, but when you take out the queuing, some movements like decrease, mainly in freezing of gait. But I think it's a good idea using the metronome since the beginning. Yeah. Have you used this metronome?
I use it regularly. For a long time. I've been using, and the auditory cueing is for me the best one. And I ask the patients to do that at home, and it really helps them. Dual tasking.
There is some apps in the cell phones, in the smart cell phones. They have some metronomes and the people walking outside, and they put like to help them. Yeah, this is really nice. I like this idea.
Thank you. So I have another question by Diana Garrido, and she asks if you recommend to work with these complex exercises, if you associate them to a training program called HIIT. HIIT, I guess it's high intensity.
High intensity training, right? Yeah. High intensity.
Do you recommend that?
Exactly. So there is one professor in Brazil, my colleague, they work a lot with a combination of strength training and aerobic exercise. They do this combination because they said it is the better combination for patients with Parkinson's disease. So I think using this logic could be good to have this complex exercise combined with this high intensity interval training. I think is the best one because high intensity interval training, you work in different aspects of aerobic and anaerobic pathways. So, but you don't have like balance aspects that are important to trigger freezing of gait. And if you include some complex exercise that are trigger for freezing and include some sensory motor integration with balance, I think it could be a great combination with high intensity interval with complex exercise. Yeah, this is a nice idea.
Good, thank you. So I have two questions by Nicolas Pardo. The first one, I'm going to read them. I'm going to quote him. Read them. He says, based on the lecture, does the vibratory component play a fundamental role in this anticipatory control that tends to regulate freezing of movement through bypass pathways involved in movement adjustment, such as the cerebellum? Is there an important relationship with cerebellar function?
Oh,
That's
yeah,
the
this
first
is
question.
yeah, so this is a good question. So here at OHSU, Dr. Manchin developed the vibrotactile cueing. And this vibrotactile cueing is a vibration cueing. And we published a paper in Neuroscience 3 years ago. And in this paper, we check which brain areas are responsible for responsiveness of this vibrotactile cueing. And we found subcortical areas, includes basal ganglia and brainstem as well. And the cerebellum was included in this model, but it was not significant region of interest. So then I think is more brainstem areas with basal ganglia could explain more this vibration or vibrotactile change when you use it for freezing of gait. There is some study show this vibration can bypass the rhythm of the basal ganglia and cause disruption in this dysfunction, and it can have this effect on gait and balance. So I think it's more subcortical areas and basal ganglia as well, and brainstem. But in our study, using this complex exercise in the fMRI, we found a higher activity in the cerebellar locomotor region. So for this, that we have a lot of complexity and you need to have a lot of coordination and the postural preparation. I think cerebellum is associated with this type. But for vibration, I think it's more subcortical and brainstem areas.
Thank you. And another question by Nicolas Pardo. In relationship to the mesencephalic locomotor region, it can be directly stimulated through emotional and voluntary pathways. But how can that activation be consolidated? Since, according to the lecture, its effects seem to last only a very short time.
Oh, so we have some studies in people in animal models. They show that neurons inside the mesencephalic locomotor region modulate postural preparation and balance. And when you cause lesion in this region, we lost locomotion and postural control in animal models. And in humans, when you cause a lesion in mesencephalic locomotor region and cerebellar locomotor region, you cause freezing of gait events. So we have this another pathway related with locomotion and motor control more than just mood signs like emotion and the other things.
Okay. We have time for one last question. Is by Dr. Paloma. She says, once you finish the 36 sessions protocol, how frequently do you recommend to keep on with the treatment?
Oh, yeah. So these patients we recruited from the Brazil Parkinson Association, is a philanthropic association that give exercise freely for these patients. So we recruited these people from there. They stopped doing any type of exercise and they started doing our complex type of exercise. When they stop our program, they return to Brazil Parkinson Association and keep this exercise program once per week, but together with the other programs like painting, dancing. So they keep really good for like 2-3 years since we finished this study. I don't have the contact with all of them, but I could tell you once per week together with other programs could be great. But again, we didn't assess these people after the protocol to see the retraction effect. So if you ask me, Carla, how many sessions after this protocol, I could say keep doing that, don't stop, because you don't have like the results when people stop. But in this case, in the Brazil Park Association, they stop our protocol, keep doing once per week, but together with other programs like dancing that help in balance as well, and rhythm, and motor thin conditions like painting.
Thank you. One last question, Carla. Okay.
Uh-huh.
Okay. So this is a question done by Jamie Dieni. Do you have did you lead a study that had evaluated the result on the long term after 6 months, after a 6 month treatment?
Oh, so there is one study, but it was a queuing study from Professor Alice Newborn from Belgium. She's amazing in this field of freezing of gait with Professor Ferrorek as well. So he developed these queuing strategies for freezing, and she followed these patients for 3 months, but not for 6. And she found the retention with these queuing strategies, but together with other programs of exercise. So we don't know like the type of exercise and the retention, like 6 months, 3 months. We don't have this information in the literature, but this is the only one that I have now on my mind about queuing and the retention.
Okay. Well,
Yeah, but
on
we are
behalf of
missing. Yeah.
Thank you. So on behalf of the association, I thank you very much for your wonderful lecture, very elegant, very clear. And I thank everyone to attend the lecture also. And I encourage you to keep posted on the website to see future seminars from our association. Thank you very much.
Oh,
Have a
thank
good day.
you.
Bye-bye.
Thank you. Thanks so much.
Bye.
Bye.